Welcome to today's Explainer. Let's jump straight into it. Today, we're exploring a truly fascinating realm of medicine, neural anesthesia pharmacology. I want you to think of the neuroanesthesiologist not just as a doctor, but as a master architect. You see, every single drug they administer is a precise, calculated structural change to the brain's physiology. They're balancing exact half-lives, cerebral blood flow, and autonomic reflexes in real time. It's a job that requires absolute, immense precision. In this explainer, we're going to break down the exact agents they use straight from our source material, going point by point so we don't leave any crucial detail behind.
Here is our roadmap for the day. We are going to cover 1. Sedatives and hypnotics, 2. Managing reflexes and autonomics, 3. Paralytics guidelines, 4. Depolarizing agents, and finally 5. Non-depolarizing agents.
All right, let's kick things off with Section 1, sedatives and hypnotics and how they protect the brain.
So these drugs aren't just about putting a patient to sleep. They actually actively manipulate cerebral metabolism. Our very first class is benzodiazepines. At their core, these function as GABA agonists, and they're utilized for two major clinical reasons: providing potent anti-seizure action and producing amnesia, which ensures the patient literally has no memory of the surgical events.
Let's look at their exact profile. The absolute critical metabolic effect you need to note here is that benzodiazepines actively decrease the cerebral metabolic rate of oxygen, or CMRO2, by lowering the brain's demand for oxygen, while simultaneously providing those amnesia and anti-seizure effects. These drugs create a much safer, more stable environment for the brain during an invasive procedure.
Moving right along to our next agent, etomidate. This one is a heavy hitter. It's used primarily for the induction phase of anesthesia, basically getting the patient to sleep quickly. Its defining characteristic in a neuro context is that it acts as a cerebrovasoconstrictor. This means it actively narrows the blood vessels inside the brain.
Because it constricts those vessels, etomidate reduces cerebral blood flow and intracranial pressure. It also drops CMR2, just like our benzos did. But here is the crazy part. Despite all of these massive reductions, etomidate does not suppress brainstem activity. That unique profile makes it a pretty fascinating pharmacological tool.
However, etomidate comes with a very detailed set of clinical caveats that you absolutely must know. Let's go through them. First, based on experimental studies, it's actually no longer promoted as a cerebral protectant because it drops brain tissue oxygen tension, or PbTO2. This is particularly noted with temporary middle cerebral artery clipping. Second, it suppresses adrenocortical cortisol production. And get this can happen even after just a single induction dose and can persist for up to 8 hours. Though, importantly, the literature notes no adverse outcomes from short-term suppression have actually been reported. Finally, it actually increases the activity of seizure foci. While this means it can induce seizures, surgeons brilliantly turn this into a major advantage, using it to map out seizure foci during specialized epilepsy surgeries. Let's turn our attention to propofol. This is a highly versatile sedative hypnotic. It's a workhorse used across the board for induction, for continuous sedation, and it's also been described for its cerebral protection qualities.
Like etomidate, propofol reduces cerebral metabolism, blood flow, and intracranial pressure. But its real superpower? A remarkably short half-life that permits rapid awakening. If a surgeon is doing an awake craniotomy, where they literally need the patient to wake up mid-surgery to test neurological function, propofol allows them to turn the sedation off and on incredibly quickly. Just remember one thing, it is not an analgesic. It provides absolutely zero pain relief.
All right, let's move into Section 2, managing reflexes and autonomics.
When a breathing tube is inserted, the body's autonomic reflexes naturally want to fight back. Our first line of defense is lidocaine. Given intravenously, its job is to suppress those harsh laryngeal reflexes and effectively blunt the massive spikes in intracranial pressure normally caused by endotracheal intubation or suctioning. Now, at low doses, it acts as an anticonvulsant, but you have to be precise. High concentrations might actually provoke the exact seizures you're trying to avoid.
Next on the list is esmolol. This is a selective beta-1 adrenergic antagonist that powerfully blunts the intense sympathetic response to laryngoscopy and intubation. Interestingly, it is far less sedating than equipotent doses of lidocaine or fentanyl used for the exact same purpose. Plus, it gives the anesthesiologist immense control because it has an ultra-short half-life of just 9 minutes.
Then we have dexmedetomidine, commonly known as Precedex. This is an alpha-2 adrenergic receptor agonist, and honestly, it's like a multi-tool. It controls postoperative hypertension, and it provides fantastic sedative qualities during those really delicate awake craniotomies, whether used alone or alongside propofol. But its most unique feature, it actively helps patients tolerate the endotracheal tube as they wake up. This facilitates a smooth extubation without relying on heavy sedatives or narcotics that might cloud up their neurological assessment.
Let's transition into Section 3, paralytics and their crucial administration guidelines.
Because these specific drugs paralyze every skeletal muscle in the body, including the diaphragm, there are absolute, non-negotiable guidelines for their use. If you take absolutely nothing else away from this section, memorize this rule. Never administer paralytics until it has been determined that the patient can be manually ventilated. If you paralyze a patient and then find out you can't actually push air into their lungs, you have just created a life-threatening crisis. The one and only exception to this rule is if you are actively treating a laryngospasm.
To make sure everything goes safely, there's a strict point-by-point checklist you have to follow. Step 1, again, confirm manual ventilation capability. Step 2, you absolutely must administer sedatives to all conscious patients to blunt awareness. Paralytics do not affect consciousness, and being paralyzed while fully awake is terrifying. Step 3, establish neuromuscular twitch monitoring to properly guide your administration. And Step 4, ensure extreme caution in non-fixated patients who have an unstable cervical spine.
Let's dive into Section 4, depolarizing paralytic agents. Now that we know the ground rules, let's look at the actual drugs. There's exactly one drug in this specific class that we need to cover. That drug is succinylcholine, or anectine. It stands completely alone as the only depolarizing neuromuscular blocking agent in our entire toolkit. Because of exactly how it functions at the neuromuscular junction, it's primarily relied upon to rapidly secure the airway during an emergency intubation.
Let's break down its exact profile. The standard intubating dose is 1 to 1.5 milligrams per kilogram. It acts fast, right? The onset is just 60 to 90 seconds, and it wears off quickly too, with a duration of only 3 to 10 minutes, though you can repeat the dose once if needed. However, keep in mind, it may transiently increase intracranial pressure. On top of that, its potential side effects really limit its acute use following an injury or in adolescents and children. And here is a clinical pro tip directly from our sources. Prior dosing with 10% of the ED95 dose of a non-depolarizing relaxant actually significantly reduces the severe muscle fasciculations or twitching that succinylcholine is known to cause.
And finally, Section 5, non-depolarizing paralytic agents.
Unlike succinylcholine, these agents block receptors without causing that initial muscle depolarization and twitching. We're going to start with rocuronium, also known as Zemuron. Chemically speaking, it's classified as an intermediate-acting aminosteroid non-depolarizing muscle relaxant. It is an absolute fundamental staple in modern anesthesia.
Rocuronium's vital distinction really stands out when we compare it to its close relative, vecuronium. Rocuronium is the only non-depolarizing agent approved for rapid sequence intubation, or RSI. Why? Because its duration and onset are dose-dependent, which allows for incredibly tight control. On the flip side, vecuronium has similar aminosteroid activity, and notably, it does not cause histamine release. But, and this is crucial, it is absolutely not approved for RSI. Knowing this distinction is vital for anyone in the operating room.
Let's finish out our drug profiles point by point with two more non-depolarizing agents. First up is cisatracurium, or Nimbex. This is another intermediate-acting agent. What's highly unique about this one is that it's metabolized by something called Hoffman degradation, which is entirely temperature-dependent. Also, it yields no significant increases in histamine. Finally, we have pancuronium, or Pavilon. Due to its long-acting nature, it is not indicated as a primary paralytic for intubation. However, it becomes really useful once the patient is already intubated, or you can use it in a low dose as an adjunct to succinylcholine, just like we discussed a moment ago.
And there you have it, a complete point-by-point breakdown of neuroanesthesia pharmacology. We've seen exactly how every single drug, from edamatate's vascular control to esmolol's lightning-fast 9-minute sympathetic blockade, serves a highly specific architectural purpose. Balancing those exact half-lives, cerebral blood flow, and dangerous autonomic reflexes requires immense precision and really deep knowledge. So, I leave you with this final thought. Based on the exact profiles we just walked through, which of these intricate pharmacological tools are you going to rely on first in your next complex neuroanesthetic case? Thanks for exploring the science with me today, and I'll see you next time.